When examining the lumbosacral spine in patients without red flags and without radiation of pain, the examination primarily functions to provide a baseline to measure change in future examinations and to assist in building rapport with the patient. When inspecting the lumbosacral spine, as well as the normal features, inspection should also consider the posture of the patient, the presence of pelvic tilts, whether there are obvious deformities, swelling or wasting, whether there are signs of trauma or inflammation, whether the skin creases both at the waist and below the buttocks are level, and whether there are cafe au lait spots. The cervical lordosis, thoracic kyphosis, lumbar lordosis, and sacral kyphosis should be examined from the side. Scoliosis is identified from behind the patient. Screening includes observation of waiting room behaviour. Next, the patient is asked to walk and to squat. Movements are tested with the patient standing. Because it is impossible to clinically determine how much movement is from the hips or from the lumbosacral spine, lumbosacral flexion must be measured. This is undertaken by a modified Schober's test. In this test, the spinous process of L4, which is at the level of the top of the iliac crest, is identified, and then points 5 cm below and 10 cm above this are identified. The distance between these 2 points is measured in the neutral position. The patient then bends forward so the spine is put into full flexion and the distance is remeasured. If there is 5 cm or more difference between the 2 measurements, then the patient is assessed as having a normal range of lumbosacral flexion. Extension is best done with the hands on the hips. About 20 degrees should be obtained. When measuring lateral flexion, the fingers are slid down the legs, keeping the trunk in the same axis. In normal lateral flexion, the fingertips should at least reach the lateral knee crease. Rotation is undertaken by sitting the patient on the couch to block pelvic rotation. It is in this position that overpressure is normally undertaken to ensure that there are no bony blocks to spinal movement. Palpation is undertaken with the patient lying face down, preferably with their arms by their side or hanging over the edge of the couch. The flats of the fingers are used for examination of the musculature. The spinous processes and interspinous ligaments are palpated with the edge of the palm. Palpation over the facet joints is undertaken with the ball of the thumb, being careful to compare the amount of tenderness with the other side. When pain radiates into the leg, a formal neurological examination must also be undertaken. Additional screening includes walking on tiptoes, which tests for S1 weakness, and walking on the heels, which tests for L5 weakness. In the example shown, the first myotome tested is resisted dorsiflexion and inversion of the foot, which is an L4-5 movement, then eversion of the foot, which is an L5-S1 movement, followed by plantar flexion, which is an S1-S2 movement. Following this, great toe extension is tested, which is an L5 movement, and finally, flexion of the other toes, which is an S2 movement. Next, resisted knee extension is undertaken, which is an L3-4 movement, and then hip flexion, which involves myotomes L1 to 3. The dermatomes are tested by light touch, comparing for differences between the two sides. When a difference is found, more formal mapping of the area affected is undertaken, bearing in mind that there is a large individual variation between dermatomal patterns. Finally, reflexes are tested with the knee reflex being L3-4 with L4 being dominant and the ankle being S1-2 with S1 being dominant. The special tests for neurological examination of the lumbosacral spine are all passive tests. In the straight leg raising test, the leg is raised until there is reproduction of the pain below the knee. Lasag's test is undertaken when a positive straight leg raise test has occurred. The leg is lowered from the position at which a positive straight leg raise test is obtained so that the pain is abolished. In the example shown, the leg is flexed, then extended, and the foot is then dorsiflexed. If the pain is reproduced, this is a positive test. A positive opposite straight leg raise test occurs when the normal leg is elevated, and this causes reproduction of pain in the affected opposite leg. In the bowstring sign, the straight leg is lifted until reproduction of the pain below the knee occurs, and then slightly flexed so that this pain disappears. Pressure is then applied in the popliteal fossa. This causes bowing of the peroneal nerve, and in a positive test, this causes pain above or below the fossa. The final neurological test is the femoral nerve stretch test, and this is only done when pain occurs in the anterior thigh. This can be done either with the patient on their side or lying face down. The knee is flexed 90 degrees. The hip is then carefully extended. A positive test is when reproduction of pain occurs in the anterior thigh. There are 5 groups of signs of behavioural or psychological distress, which are also called Waddell's signs. In the first group, there is overreaction, grimacing or clutching of the body, and the furniture may be used for support as is demonstrated in this example. In the next group, pain is caused with simulated forces, either with axial loading where very light pressure is applied on the scalp. In the positive test demonstrated, the patient complains of pain in the lumbosacral spine. In simulated rotation, the hands are held against the hips, bracing the pelvis, and the body is gently rotated. A positive test is a complaint of pain. In the third group, tenderness is much more widespread than is possible to have developed from a lumbosacral injury. Superficial touch may also cause substantial pain. In Group 4, there is regional discrepancy in motor and/or sensory function. There may be a glove and stocking sensory deficit. Weakness may be found over multiple myotomes. Perhaps there may be muscles giving way, such as with cogwheeling, as is shown. In the final group, there may be a discrepancy in straight leg raising when this is examined in different positions. This is shown with the patient sitting on the edge of the examination couch, with the patient lying down, and it can also be done by asking the patient to sit up along the couch to have his or her chest examined.